want to thank the organizers, Julio and Naida in particular, for inviting me to speak. And I just wanted to take the prerogative of having the mic at the moment to invite you all to take the gloves off. I think we've been all very polite during the past couple of days, and I know that many people in the room, like I do, believe that this intervention could be really, really important and life-saving. And I think our job maybe is to hone the argument as much as we can to provide it to policymakers and really come up with the best possible defense for implementing treatment as prevention now. And so if we can do that by sharpening our questions a little bit, I invite you, and I'm up here to take your sharp questions if you have any for me. So to go on to what I'm going to talk about, I don't pretend to really be able to summarize the situation in Latin America. I am going to speak about a study that we hope to roll out soon in Peru. So just first to look a little bit at Latin America, this is a slide from Chris Duerr looking at the prevalence in MSM compared to the prevalence in the general population for Latin America and one African country that he put in this population. And you'll see Peru here with a really predominant MSM epidemic, very high prevalence in MSM compared to the general population. So in Latin America and Central and South America, in 12 of the 14 countries examined in the recent WHO report, prevalence was over 10% among MSM. And in Lima, where we're working, a variety of studies over the last 5 years have shown an incidence in MSM between 3.5% and 6.2%. So this is quite a high-risk population, a population in which alcohol and cocaine use are major drivers of sexual risk. And we're going to be looking at this in the study that we hope to launch soon with support from NIDA. The system in Peru is one that's actually quite highly evolved in terms of community involvement. There have been, for the past decade, a series of government-supported peer educators that bring MSM in their community to federally funded testing centers as well as NGOs. And there's been some recent relaxation in these recommendations, but up until fairly recently, the government recommended and supported testing every 3 months for high-risk groups, such as MSM. And the government also does support ART with initiation at CD4s of 350. So that's kind of the background in which we're working. This is again a slide from a recent study by Chris Duerr looking at what might happen in Peru over the next 5 years. Looking at the current situation, if interventions are not scaled up, by 2015, 95% of the cases in Peru will be among MSM. And Chris looked at just the effect of rolling out 3 interventions, and those were provision of condoms and water-based lubricants, community-based interventions for MSM, and full implementation of ART treatment along current guidelines. And that's the blue line here. So you can see a significant impact on where the epidemic would have gone without these interventions. So as I said, we're going to look at some specific characteristics of MSM. These are recent data presented at CROI by Brenner in Mark Weinberg's group. And this is an update on a paper that was published in JID in 2007 looking at cluster transmission. So this analysis took advantage of phylogenetic data that was available through resistance testing to look at clustered transmissions. And the inference from that data looks at the proportion of new infections, and this again is looking at recent or primary infections now just in Montreal among MSM. And their inference is that 36% were unique transmissions, 24% occurred in small clusters, and roughly 40% occurred in large clusters. And their interpretation is that these are clusters that are driven by onward transmission that occurs during acute infection. And this is a question that we're particularly interested in and one that we're going to look at in Peru. So this just schema just to point out that much of looking at the transmission probability based on viral load at different stages of infection. And we all know shortly after infection viral load is very high, and we anticipate that this will be a time of high rates of onward transmission, even though this is a fairly short period. Then we have, relatively low viral load and very, we think, substantially lower risk of transmission for a number of years. And then, as we know, when viral load rises and low CD4 counts, again, we have a higher rate of transmission. Much of the transmission risk in this period will probably be, we hope, eliminated by treatment along current guidelines. And many of the treatment for prevention interventions will target this period. So we're trying to ask the question, can we incorporate the period of acute infection as well to treatment as prevention interventions? So the research questions that we hope to ask are really feasibility questions. Can tests that detect acute infection be incorporated into routine testing? So this would be P24 testing, as well as some newer pooled NAT testing, and hopefully eventually point-of-care viral load testing. But again, that'll be in the future. Then we're going to be looking among men who have recent or acute infection, how rapidly can viral load in semen and rectal secretions be reduced to undetectable by ART treatment. And then we'll be mapping transmission clusters using a combination of contact tracing and phylogenetic analysis, as well as some other sampling of clusters among MSM in Peru. And then finally, we'll be asking the question about, can we increase adherence to ART among HIV-infected MSM with alcohol use disorder through the use of extended-release naltrexone. So that's all my comments. I look forward to your questions. Thank you.